Welcome, everyone, to the Health for the World COVID Grand Rounds. We have a global audience today and really excited to introduce our guest faculty to the program. Dr. Sam Shen. He is Clinical Associate Professor in the Department of Emergency Medicine at Stanford University School of Medicine. He's also the Vice Chair for Clinical Affairs in the Emergency Medicine Department and has been instrumental in sort of leading the emergency room preparedness in the time of COVID here at Stanford. And we are really excited to have him with us today. Please feel free to share your questions in the Q&A chat format, and we will answer them after some initial thoughts. And I would like to have Dr. Shen take it from here. Thank you.
Thank you. Thank you very much, everyone. I appreciate the opportunity to share what we've been doing at Stanford Department of Emergency Medicine, as well as at Stanford Health Care. And as you can imagine, COVID response involves a whole crew of people. So clearly I'm speaking on behalf of many of my colleagues, administrative staff, nurses, and just a lot of people that have been involved in this. And but I would like to start by just sharing a little bit about Stanford and giving a little bit of background. And so our emergency department is part of Stanford Health Care. We are a level 1 trauma center. And as part of being affiliated with the university, we are a teaching hospital. Like many level 1 centers, we have stroke, STEMI, receiving facility. We have about 86 treatment spaces. In our ED, we see about almost 80,000 patients a year, and that has been growing about 3.5% every year. We admit about 23% of all the patients that show up, and we have, as you can see, a fairly large crew of nurses, physicians, residents. And we recently just split up our emergency department last year into a pediatric emergency department and a adult emergency department. So this just gives you a context of this space and the environment that we are working in. In the past several years, you'll see each line as it goes up. We've been seeing more and more patients every year. And the reason this is, I wanted to highlight this is just because when we opened a new hospital, like many new hospitals, you'll see the volume increase. And it's the idea that if you build it, they will come. And so we've been increasing our volume on a daily basis. And so this is just our average number of patients we see per day. But recently, what we noticed is when we went into the COVID pandemic time period, our volume has dropped. And so this is how many patients we're seeing every day. At one point in early March, we're seeing close to 300 patients a day. And volume has now declined as much as 40%. And so we're seeing now 60% of what we used to see. And this phenomenon is not unique to Stanford. Across the country, and also in our Bay Area, Northern California, many community emergency departments are seeing volume drops of 50 to 60%. And we believe this is because, of course, with the idea of social distancing, staying at home, that has been a big part of it. But also just the idea that it demonstrates that in the United States, much of the care that we see in the emergency department can often be seen in the primary care setting or in an urgent care setting, and that the percentage of patients that are showing up with a true life-threatening emergency is smaller than what we typically see. So when we think about our preparedness, one of the things I want to touch on is our testing. We are fortunate at Stanford to have the test early on in around March 3rd, March 4th is when the Stanford developed their own test for COVID-19. And so in the early stage, we're using the Center for Disease, we're using the CDC for the criteria for who to screen for COVID-19. And the criteria was very strict just because the testing capability was very limited. You had to send the sample to your county, which then goes to the CDC. And in our emergency department, and that's just a layout of our footprint of our emergency department on the left-hand side, of the building. I starred the rooms that we had that are negative pressure. So we had to put the patients in a negative pressure room to test them. And there's limited numbers of like negative pressure room. We could also put a patient in a private room with a HEPA filter, but again, that takes additional resources. So knowing that the number of patients were going to start increasing at Stanford, we needed a better way to test patients, especially the ones that were not very sick, who came in with cough, fever, etc. So we put some tents outside of our emergency department. And this is just right outside our ER. And we put up these isolation tents where we could put an individual in there. The nurse could then do the assessment, followed by the physician could then also assess the patient out there wearing the appropriate protective, personal protective equipment. And in doing so, we could save the space in the ED for patients who are really sick. And the patients who are otherwise well that can go home but need to be tested can then be tested in this environment. But because the space was limited, we knew that we were going to expect more patients to show up. So we needed to do, we need to build on this and allow more capacity to test patients. So the next phase was what we call the drive-through testing. And this drive-through concept, especially in the US, is the idea that a car can just drive up and then have all the services converge onto the patient in the car and do so in a much more convenient and efficient way. So we would screen the patient, we would register them, the nurse would do assessment, the physician would then assess using telemedicine, and then we would swab and then discharge the patient. And it was inspired by this idea that this NASCAR race, car race, where a crew of people would just come and converge on a car and do everything very quickly, and the car can then go off and continue to race. So we set up a screening process where just outside the emergency department, there would be a nurse asking questions. And if you met these criteria and the nurse assessed you to be someone that's not very sick, you would be diverted to our garage area in the parking lot to be tested in the drive-through method. If you were sick, you would come to our emergency department and put into a room like any other patient. The patient would then scan their driver's license and text that to the registration person while in line, and that registration person can then register the person. So as the person is driving to the garage, then they can already get the patient into the system. And this would take less than 1 minute. They would also note the color of the car as well as the make so that they know how to track which patient is in which car. The patient would then be diverted into the, I know it says exit, but that's actually the entrance to our garage process that we took over. So they'd be diverted into that area. Once they're in that area, we set up the space essentially so that it could be a mobile testing zone. They put up Wi-Fi, there was a generator for electricity, there were printers, there were barriers, there was someone controlling the traffic, there were even hand washing station. And as you can see, all the equipment is set up so that as a car pulls up into the lane, and there's 2 lanes that can hold up to 6 cars each, that then you can process the patients while in the car. Here's a picture of the registration folks in front of the cars that would then register the patients. Every day they would pull up their computers, they would set up the heaters, put up the pages, put on the appropriate PPE. And then while the car is in the designated area, the nurse, after doing their assessment, would pull a telemedicine call right up to the driver's side or the passenger side, depending on where the patient's at. And the physician, we have a dedicated physician in the main emergency department that would then do a video visit with that patient. And typically it lasts for a couple minutes. And if they confirm that the patient meets the criteria for COVID-19 based on symptoms, they would have standing orders that the nurses could use to then swab, test, and send the patient home with discharge instructions. If the patient didn't drive in, but walked in, we had a separate area also near the garage where the patient can sit in front of a telemedicine unit and also be seen by that same physician. In doing so, this is the volume of our patients in the blue line of the people we tested using that drive-through methodology. The line in red are the ones that tested positive. So fortunately, there were not a lot of people that tested positive. Now, one thing you'll notice is that when we first set this up in early March, you can see the spike in volume. And then as the Stanford Health Care increased their capacity to test patients on an outpatient ambulatory basis, so the Stanford Express Care, Stanford Primary Care Clinics, they were able to start increasing their testing. Then they were able to then offload a lot of the testing from the emergency department. Because from a resource perspective, ideally, these patients who are well, who are not very sick, they should not have to come to the emergency department to be tested. But again, early on, the emergency department was one of the few places that was able to do this. And so having this capacity to do that definitely helped our patient population. And we are still testing a lot of people, but it's just that the tests now are done on sicker patients who have to come into the emergency department. So this is just a graph for those that are coming through the drive-through. Another way that we use technology for COVID-19 is we deployed about 120 iPads into every single patient room, plus the physician work area and the nursing work area. And we did this because this reduces the amount of masks and supplies that we need to use. So in each room, this would be at the near the patient's bed, near the head of the patient's bed, and we would have an iPad in the physician work area. We would dial into the very specific room that we wanted to talk to the patient, and we can communicate back and forth with the patient. The nurse can do this, can staff, and this has helped reduce the risk of exposure as well as reducing the equipment. And this is much more cost effective than some of the big telemedicine carts. In fact, an iPad being as potentially as cheap as a few $100s compared to several $1,000s for the big telemedicine cart made a huge difference. Here's a view of us looking into the patient's room. We also have scribes. These are oftentimes pre-med students that are documenting for us, and they can be outside the room listening in while we examine a patient, and they can document with us. We also use the iPads for consultants. So we need to call a psychiatry consult, a cardiology consult. They can also examine and see the patient through telemedicine. Of course, there are a few times where the consultant needs to touch the patient. If that's the case, they have to go into the room. However, majority of the time, our consultants can examine the patient by telemedicine, by visual. Another technology we're using is bedside ultrasound. Bedside ultrasound is a huge part of emergency medicine practice. We used to have to roll in these big machines into the room to examine the patient's abdomen or heart or lungs. But with these portable ultrasounds, these are butterfly ultrasounds. As you can see, they're the size of an iPhone. You just go into the room, you plug it in to the iPad that's in the room, and so you use the iPad as a monitor, or you can use your own iPhone. Now you have a portable ultrasound that you can wrap in a disposable plastic sheath. And then when you're done, you throw away the plastic, and you then decrease your chance of infection and having to clean the big machine. And so this was something that's very, very useful. Another use of technology or a different change in practice was x-rays. So we worked with our radiology colleagues so that if we need to shoot an x-ray with a COVID patient in the room, the radiology can slide the plate into the room. Our doors happen to be glass, and so they can shoot the x-ray through the glass door, and again, reduce the chance of infection so that radiology tech doesn't have to be in the room, and that machine, that portable machine, does not have to be clean. The patient does not have to go to the radiology suite. And again, this is a win-win for everyone. You see a picture of the nurse standing behind a lead shield while the x-ray machine is shooting through the glass. Next, I wanted to talk about how we are planning for a potential surge or disaster. A lot of the models have predicted that in the next week or possibly 2 weeks, we may see a surge in volume, similar to what they're experiencing in other parts of the world and other parts of the country. I want to talk about 6 principles that we developed to guide our planning. The first is that we wanted to have a tiered approach to our disaster plan. It was not going to be an all or none, where one day we wake up and all of a sudden we're in a disaster. likely it's going to be ramping up. And so our approach to managing the surge in volume should also be staged. We want to try to separate patients that are what we call PUI, person under investigation. So these are potential COVID patients, from people who are not potential COVID patients. We don't want to mix them together. So when we design our disaster surge space, we want to keep that in mind. We want to save the rooms for the sickest patients and patients that don't need to be in a room who are well. We're going to use what we call alternative care spaces. And because we're going to need to expand into using different spaces. We want to continue to use as much virtual medicine as possible. So even in a disaster, we want to try to use technology. We want to try to do telemedicine to decrease exposure and decrease use of, again, the mask and other PPE, personal protective equipment. Our pediatric patients in our Pediatric Idi, which is called 300P, that's just the name of our Pediatric ED. We want to keep the pediatric patients together. We don't want to split them up, whether they have COVID or not COVID. Now, fortunately, COVID has not impacted the pediatric population as much as adults. So that it has been helpful. So we have not had to be as concerned as with adults. The first thing we wanted to do as part of our planning was to account for our capacity of healthcare workers. So specifically, we could look at how many physicians, residents, nurse practitioners, physician assistants, nurses, techs, secretaries, scribes. We can look at how many we staff every day. We can look at how big the pool of people we have. How many people can we expand to by hiring more or tapping into additional pools of nurses, for example. Then we can account for how many of every type of healthcare worker we have. Then we can make assumptions about what COVID could do if, say, for example, 15% of our healthcare team got sick. And so based on that, we can say this is the total number of people we have. We also wanted to protect our healthcare workers, and we did this by a few strategies. One, we deployed what we call precision scheduling. So every day we look at our number of patients and we try to project out the very next day, so that as our volume has been decreasing, we try to remove nurses and physicians from the hospital, from the emergency department, so that if we don't need them, they shouldn't be at the hospital where they could potentially get exposed and be sick. And that way they can be at home resting and hopefully being well. So when we do need them, we can then pull them back. Because otherwise, usually how emergency departments are staffed is every day the schedule looks the same. Well, we want to be more precise than that. We also created different types of shifts. So there's no risk, low risk, and high risk shifts. So if you work in a high risk shift, you're working with a lot of the COVID patients. If you're working in the low risk shift, you're working with non-COVID patients. And the no risk shifts are the ones where you're not in front of the patient. And these are our telemedicine shifts. We also wanted to create psychological support and hopefully provide wellness for our physicians and nurses. So we work with our psychiatry colleagues. And just last week, they did a group session where people can voluntarily join this group session virtually. And our psychiatry colleagues led this session to talk about psychological well-being. They call it psychological first aid, because we know that people, especially in the areas that have been hit hardest, have experienced post-traumatic stress disorder. And so we wanted to help build that resiliency before we get into that disaster scenario. Another way we can help our staffing is that our nurses in California have certain ratios. So one nurse can care for 4 patients, for example. So if we hit a surge or capacity where we need more people, more nurses, they can flex up. They can see more patients per one nurse than normal. On our physician side, we also added a on-call pool. So every day we have an additional 4 to 5 physicians that have signed up voluntarily that we can call on to come in if needed. And this helped the planning going forward. Next, we looked at our space. Space is a huge constraint. And so in our current space, we can account for all the rooms in our adult ED, which is called 500P, and our 300P pediatric ED. We can count that we have 95 spaces currently. We can look for additional spaces of 127 that we were able to find for a total of 222. So if we needed to, we felt comfortable we can identify 222 spaces to care for patients if we needed it. In our county, we needed to now project how many patients we think we're going to see. So in March, we started doing the projections, and this is in our county, which is Santa Clara. We were noticing that Santa Clara, the number of cases were doubling every 5 to 6 days. Now, recently, we're now into the second week of April, that number has increased to now doubling time of probably more closer to 12 days, which is good because that means that the curve is going to be flatter. Now, at Stanford, at our hospital specifically, in March, the number of cases coming to Stanford that were COVID positive had a doubling time of originally around 9 days. Now it's much, much higher than that. It's actually closer to 20 days, which again means that that curve is much flatter. So the reason that's important is because we have models now that can help predict what we think our volume is going to be. And so using a doubling time of 9, we can then plug that in, and each line represents a type of patient. So if you are a potential COVID patient and you are very sick, that's that orange line just under the green line. But on the very bottom line, the lowest line, that orange, the other orange line, or dark orange, is the COVID patients that are, I'm sorry, I mixed it up. The first line that I mentioned was the not very sick. The bottom line, the dark orange line, is the COVID patients that are very, very sick, the ones that we may need to intubate or that have to go to the ICU. And that's the line that we worry about the most because they require the most number of resources. So in this model, if you believe the projections with a doubling time of 9 days, then it looks like we may hit our capacity next week. But as I mentioned, with more recent data, we know now that our doubling time of COVID cases has stretched out. So it's more closer to 12, 15, and even 20 days is what we're seeing. And on this side, this is now the number of patients, the census, in our ED at any given time throughout the day. So between 1 a.m. to the following midnight, you can see that these are the projected number of patients that will be physically occupying spaces. And if you assume a doubling time of 6 days, then it looks like we're going to exceed our capacity. However, if you look at a doubling time of 9 days, and now again, much higher than 9 days, it looks like we should have the capacity. And so, so what I'm trying to convey here is that based on the projections, and especially more recent data, we feel a little bit more optimistic that the surge may not hit as hard as we had originally predicted back in March. But should we need to surge or hit a disaster, as I mentioned, we have a tiered approach. We will start from our current state, we will move to what we call a surge state, and then potentially a disaster state. And the triggers for each of these states would be based on data, based on our volume, our predictions, how many sick patients we're actually seeing, and what the space constraints. So based on that, we may need to then move to a surge scenario or disaster. And one of the ways I alluded to in terms of how we think about how we use our space is based on what type of patients we're going to see. So we wanted to categorize everyone into either you're COVID positive or you're COVID negative, or again, you're a person under investigation for COVID, or you're not a person under investigation for COVID. And then you're either very, very sick or you're not very sick. So these 4 buckets of people are very important because they require different level of resources, and they potentially would either go home or come to the observation area or be admitted to our floors or our ICUs. So here's an overview of our entire hospital. On the left-hand side is a section of our adult emergency department where most of the COVID patients would go. And you'll see that if we start to surge, what we would do is consolidate all the COVID patients and possible COVID patients into those red areas. And those names, Alpha, Bravo, Cardinal, FT, those are just names of different sections of our emergency department. And so we'll consolidate the sick COVID patients into those areas. That delta zone would be for non-COVID patients. So the reds are in COVID, the gray are for non-COVID patients. We also have that garage that I mentioned earlier where we were doing the drive-through testing. So patients who are not sick, who are possible COVIDs, will continue to be seen there. We would then expand into some additional areas. And so the areas we could expand into, one would be our lobby area and our triage area. We would continue to see COVID patients there that are less sick. We would use tents outside of our ED, which we were using for testing before. We would staff that area and start seeing less sick COVID patients there as well. We would take over that radiology area where you see that gray box that says RADS. That's an area that's in the Department of Radiology that is not, that we would basically take over and start seeing patients there as well for non-COVID patients. And then we would put a large tent outside if we needed to. And this is a bird's eye view of of just the emergency department side of our hospital. We would place a very large tent. It's a 30-foot by 30-foot tent that we would then, again, create a little mini ED zone just outside. If we needed to expand beyond that surge, and now we've hit a much higher volume, at that point, we would call a full disaster. And if that was the case, we would look over to our 300P, which is our Pediatric Idi, which is about a few hundred yards from our main adult ED. In our 300P area, in the gray box, that's our Pediatric ED. We would take over the space adjacent to our Pediatric ED and turn that into a mini ER. We also have spaces just outside of the emergency department. We called it our former fast track, is a space that we used to use in the past. We had a Kappa zone that we used to use in the past. And we had a CDU, a clinical decision unit, that we also used in the past, that we would convert that into patient care areas. So in doing so, this allows us to ramp up and create space for additional patients that hopefully we don't need, but in the end, we feel much more prepared that, again, we want to be over-prepared but hope for the best. And based on the most recent data, it looks like we have reason to be optimistic that we may not see the huge spike in patient volume that we are projecting. So with that, I'd like to stop and conclude my slides, and hopefully that gives a good overview of how we are approaching how we test patients and how we are managing them in a surge and disaster scenario. So happy to now open it up and answer questions.
Thank you, Sam. Wonderful. This was wow, lots of sort of innovative solutions that we've come up here at Stanford, from spacing to staffing to technologies, modeling, sort of predicting and planning. I can see how you've got a big team and a great team. So thanks for sharing all these insights. For our audience, as a way of reminder, Dr. Sam Shen is a faculty in emergency medicine at the Stanford University School of Medicine, and he's also the vice chair for clinical operations in the emergency department. So he is truly leading the effort here for COVID preparedness at Stanford, and we are very lucky to have him with us today. I am, as a way of reminder, Dr. Ankur Barija. I am a founding faculty at Health for the World, and also geriatric and palliative medicine faculty at Stanford Medicine. And at Health for the World, this is a 501c3 nonprofit sort of coming up with global health solutions around technology, education, and engagement. On that note, I see our registrants were from various countries, from India, Bhutan, Saudi, Cameroon, Tanzania, Kenya, and in many states in the United States as well. So we did get some questions from our registrants sort of during registration. So I'll quickly, I have those questions as well to go over, but I know we're getting some live questions in the audience as well. So feel free to keep putting adding live questions in the chat, in the Q&A, and then we'll come to those in just a few minutes. Sam, I know you talked a great bit about sort of surge, disaster planning, and preparedness, and it sounds like you can never be enough prepared, and sounds like we've been lucky so far that we've prepared well, and the doubling times have slowed down. Can you sort of take us through the first few days and weeks? Sort of, was it early February or mid-February when things were starting to sort of bubble up in California, and looking at Italy, looking at Washington, anything could have happened here, right, in a moment of days or weeks, and what was that like, and who are sort of the key partners you're looking at when you're sort of looking at this planning at this scale?
Yeah, so that's an excellent question. So early on, like you said, kind of around mid to late February, Stanford obviously recognized that COVID-19 was going to pose a very significant threat to our patients and to our resources. And so Stanford as a whole mobilized what we call a virtual command center. And so in any disaster planning, you would have a command center structure that can coordinate all the efforts, because it takes a huge team. At that time, they put together a virtual command center. So effectively, a lot of the same people. They set up a steering committee, kind of a body that would, of all the leaders, physician leaders, administrative leaders, that would oversee the response. And within that, there was probably at least 8 to 10 groups that covered all the different aspects of the COVID response. There was an emergency department work group, an ICU work group, supply chain work group, communications, disaster planning. As you can imagine, there were many teams that formed that reported up to the command center, or the virtual command center. And one of the things that got identified very early was the need to be able to screen patients. And so the emergency department, being the front door to the hospital, we were one of the very first to develop the screening criteria and process, because before it was widely disseminated. Of course, if someone felt sick and was concerned, they would walk right up to the emergency department. Even if they went to the primary care physician, they did not have the test yet. And so they would have to come to the ED to be appropriately screened, because you have to get the swab, the nasopharyngeal swab, and send it to the county. You have to call the county every single time you thought someone had a potential COVID. And so you can imagine now where we are testing 400, 500, 600, 700 patients a day. You can't possibly imagine that you would call someone every time that walked in. But early on, when you were getting 1, 2, 3 patients at a time, and everybody's like, is this the flu or is this COVID? But you couldn't tell. And so if they met the criteria, which is very strict, you would then call the county. They would say, okay, yes, we think this could be COVID. Please send us a sample. Then they would send it to the East Coast, 3 hours by flight away, or 5 hours. And you get an answer in probably a couple days. But fortunately, early on, the Stanford was already developing their own PCR test. And so on March 3rd, they went live with their own test. And it got FDA approved under emergency use authorization. And that was a huge game changer for Stanford to be able to now test patients in-house. That test took 24 hours as opposed to, again, 3 days, 4 days, 5 days. Some other places were taking up to 7 to 8 days. This test allowed us initially to test 40, 50 people a day, quickly went up to several hundred, and now we can test up to 2,500 patients a day. So early on, we'd screened for patients in the ED, and we were doing maybe 5, 5, 6 a day. Then we start to see the volume go up and up and up. obviously as we went from early March, late February to now mid-March to now end of March, it just went up dramatically. And then during that time, we the CDC, our county said, please don't call us anymore for the PUIs. You guys make that decision. We are overwhelmed, which makes sense. I mean, one county office cannot manage, the potentially thousands and thousands of cases. And so the response team, our command center, then continued to start the planning, and the focus early on was on resource, very much on resources. What resources do we have? What beds do we have? What ICU beds? What ventilators? What masks? So supply chains was huge in terms of making sure we can secure enough supplies of N95 masks, and they did a fantastic job of making sure those supply chains remain open as much as possible because everyone's competing for the same N95s. We had administrators and physician leaders that then start planning for ICU beds. How many ICU beds we have? And so they were able to then say, okay, we can double the number of ICU beds. They were looking at how many ventilators we had and then how many more we needed to purchase. And so, and then there was also a communications infrastructure put together, because you can imagine a lot of physicians were asking questions, a lot of nurses, a lot of non-healthcare workers were asking questions. So they put together a content that went onto a COVID website at Stanford that helped disseminate the latest information possible. And the physician leaders formed a physician communications group to also help disseminate information, because early on, everybody, it was just overwhelming the amount of information that was out there. And how do you disseminate that? How do you organize that so that physicians feel comfortable answering questions to their patients and also caring for them? So those were, I would say, kind of some of the things that were happening at the early stage. Even now, all those same structures happen every single day. It just, the intensity of it, of course, has changed compared to the first month. At one point, we were these subgroups, this command center was meeting every day, 7 days a week. The work groups were often meeting twice a day, every day, 7 days a week. And so there was just a lot of activity, again, just preparing for this surge. Stanford has a lot of researchers that are on the data analysis side. And so a lot of these researchers, population health researchers, epidemiologists, etc., they were doing a lot of modeling with some PhDs that obviously very, very smart and bright and created a lot of models. So early on, we were able to access some information to help plan, again, for what the curve would look like. So hopefully that answered the question in terms of kind of how we were, how Stanford as a whole was approaching the COVID response.
Mm-hmm. Thank you. Wow, that's quite a undertaking in terms of disaster planning, those of us who are new to all of this. We're getting quite a few questions sort of around actual sort of clinical care in the ED, and so moving from preparedness to let's jump to some of these questions and to see what have your observations be. The first one is, did you see a decline in patients coming to the ED with other clinical presentations like stroke, MI, heart failure, sort of the usual emergencies? Yeah,
interestingly, we have. And so there's been a lot of discussion about this phenomenon, that why is it that when, in fact, it's almost like a national social experiment to have, as a country, everybody stay at home, and what happens? Well, you would think that the rates of STEMIs and MIs and strokes should still be the same, because that should be agnostic to the greater environment. However, interestingly, is we have observed less patients coming in for acute strokes and MIs, and we don't know why exactly. I mean, we speculate that some of it might be air quality, or some of it might be stress, or other lifestyle, social, economic reasons. Some of my colleagues are actually going to study this. We're looking at all the data, the pre-COVID, during COVID, and post-COVID, and we want to study the demographics, the characteristics, the acuity. We really want to analyze, our patients coming to the ED before and after, to see what can we tease out and understand about how people use healthcare, especially the emergency department. We don't have the data yet, But absolutely, we have noticed that, and that's not just our ED. It's many other emergency departments are noticing the same phenomenon.
Well, there's a couple of questions around ventilator use. Um, how about the availability of ventilators, and how many equipped in the ED, and what percentage of patients who presented have needed ventilation so far?
Yeah, so I would say right now, again, we've been very fortunate. Our experience has not been, say, for example, in New York, where it sounds like, from my talking to my colleagues, that a vast majority of patients coming to the emergency department are very in stages of extremis, where they are already at that respiratory failure stage. Many of the patients we're seeing, I would say about 40 to 50% of the patients coming to our emergency department are coming in as possible COVID. I mean, these are people that we are going to test. Of those, I would say, and that's probably about 50 a day, 50 to about 75 a day. Of those, I would say probably about 5 to 6 have tested positive, and out of that 5 or so, maybe one every other day may need to be, or half a patient may need to be vented. So again, these numbers are very small relative right now. And of course, that's not what we're worried about. We're worried about that if the projections are true, then of course, then that half a patient a day could be 10, 20, 30 patients a day. So in terms of ventilators, I want to say we might have like a couple hundred ventilators in our system. And so early on, they wanted to increase, so they were trying to secure to try to potentially double the number of ventilators. Again, because of the volume we're seeing right now, we have not had to tap into that. But we currently have the resources that we need for somebody who needs to be vented. And again, it's we are very fortunate right now to be in that state.
Mm-hmm. No, you're right. Really, sort of lucky there. Specifically, there's a question around how do you manage your code stroke patients in the ED?
Yeah. So being in a level 1 center, which is different from a community hospital, I came from a community hospital setting, and so it is different. So in an academic hospital, we have a stroke team made up of neurologists that when we call a code stroke, so if someone's coming in from home and they are a potential code stroke patient, the EMS will call ahead to say they're bringing the patient in. We will meet that patient in the CT scanner. And so it's a direct from the EMS to the CT scanner. So that way, our door to CT time is oftentimes less than 10 minutes. And we will then have a read by radiologist within, probably 15 minutes to 20 minutes. In the COVID environment, if the EMS can give us history about the patient's symptoms, that this patient had cough or sore throat or anything from family or from the patient, then we would treat that patient as a possible COVID patient. That everybody who's at the bedside would wear appropriate mask, gown, goggles, etc. If we can't get any history, or there's even a concern that the history is not reliable, then we will also don the appropriate PPE. So all that is done. Same thing with our traumas. If a trauma patient comes in and there's the information is not robust enough, we will err on the side that this patient could be a PUI, and people have the appropriate PPE. So.
And have you been seeing sort of higher incidence of thromboembolic sort of events? We've heard in other sort of studies that higher thromboembolic episodes or VTE in COVID patients. Have you seen more of that here with strokes and others?
We have not. I mean, we've seen kind of the anecdotal here and there. I happen to have, one PUI patient, a couple weeks ago that also had a pulmonary embolism, but eventually screened negative. And so, and they have some that screen positive. So again, I would say that, it's anecdotal, not that we don't have, I don't think the volume and the vast numbers to be able to see if that's been a pattern.
Okay, we've got a question around sort of if you know what percentage of patients are dying. I know it's not been a high number here, at least luckily at Stanford, but your thoughts there?
I don't have the exact numbers, but I would say it's very, very low. Now, what the experience has been, I think worldwide, has been about 80% of COVID patients to 85 need to be hospitalized, and then the remaining 15%, 5% have been typically ICU, and then of the ICU, the subset of that is probably 2%. So probably 2%, 3%, and I suspect ours probably will match that as well. So again, very, very low.
Okay. There's obviously concern with healthcare workers sort of getting infected with the virus everywhere, nationally, internationally. Question around, there's around 9,000 US health workers who've been infected. What causes that? Do you think, is it just human error? Sort of operationally, standards are not as robust? What do you think are some of the things, key sort of principles there we need to sort of follow to?
Yeah. Obviously, every hospital will have their guidelines. Most hospitals will have an infection prevention and control. And, we rely on our group to provide guidance. And our infection prevention and control team, which is made up of infectious disease experts, epidemiologists, and nursing, they also take direction from the, of our CDC, also in addition to WHO. But I would say early on, we wanted to make sure that we follow the best practices for other disease models. And in the beginning, I think there's still some controversy of whether COVID is truly airborne or not. We are treating it as an airborne, but early on, even the CDC website would say that it is, droplet, and it is not, they could not confirm that it is airborne. But having said that, we still treated it as it could be airborne, meaning that it could be aerosolized. And so in order to take care of someone with an aerosolizing pathogen, the N95 was the standard for if you need to be in close contact. And so having the appropriate equipment is obviously the important step. Appropriately screening patients is also very important. And so we put a nurse outside our emergency department so that nobody can come in if they screen positive. And if they screen positive as a potential COVID patient, then we make sure that we put them into a private room or negative pressure room so that they don't then contaminate other people or healthcare workers. The third part of PPE that's really important is putting it on and taking it off appropriately. And so, a lot of errors can happen when you take off your PPE. And there's a very specific recommended sequence for taking off your goggles, your mask, your gloves, your gown, etc. And if you don't do it appropriately, you can contaminate. And so we made all of our physicians go through retraining on how to put on and take off the PPE equipment. And in fact, we tested them. So everybody had to go through where we had a third party watching several of our physicians as they put it on and then take it off, and they have a checklist to check to make sure they did every step correctly. And so again, it just to emphasize that it's so important that you put it on correctly and take it off.
Thank you. Yeah, cannot emphasize that enough. Luckily, we've had appropriate PPE here at Stanford and have not seen shortage. I have some final questions around, special sort of high-risk populations, especially sort of the older adults, multi-morbidity, advanced sort of malignancy, and so forth, coming in. Even if they're stable, they could go into a rapid decline anytime. As we know, they're sort of a higher risk cohort. How do you sort of envision the value of involving palliative care and geriatrics sort of colleagues early on, maybe into the emergency room? I know we know some of the EDs sort of nationally, Mount Sinai, UW, have had to sort of do some of that. But what's, if we need to, obviously, as volume, if and how do you envision some of the role for these patients?
Absolutely. I believe palliative care plays a very important role, and this is why we have a subgroup where one of our emergency physician medical director has been working with the palliative care team as well as the ICU critical care team. So these three stakeholders are part of a group to look at end of life care in the COVID environment. It's brought in issues around ethics, around crisis standards of care. And so we are taking direction from this group to help us determine what the best practice is. Should we encounter that scenario for, again, the patients who are very vulnerable towards the end stage. And this is definitely an area of interest because what we've heard from other hospitals that have encountered this is they've had to make very tough decisions with family, with the patient. And so to be prepared for that, this is the reason why we wanted to kind of pull that team together, palliative care, ICU, ED, so that we can kind of come together with some common strategies and approaches. And they are actually going to formalize it into very specific guidelines and kind of standard care practice models. And so, yes, so to have it kind of formalized into almost algorithms and protocols kind of will give people more reassurance in terms of how to approach that difficult topic.
Okay. Well, we're coming up to the end of the hour. It's been a busy couple of months for you, and I know for our ED colleagues there and everywhere internationally, you're really on the front lines. So really thank you for everything and your colleagues. Any sort of thoughts around wellness? How in this time, how have you been able to take care of yourself? And what do you recommend to your colleagues? It's especially the days when things are uncertain and both on personal and professional ends, right? There's a lot of uncertainty.
Yeah, well, I keep hearing a lot of our saying is that social distancing, does that mean social isolation? And so our team has done virtual happy hour, virtual cocktail hours on Friday at 5 p.m. And so it just gives people, even if it's by Zoom, it still just gives people a chance to connect. And we're trying to encourage people that, again, if you don't have to come to the hospital, stay home and, spend time with your family and just rest. Again, we're, trying to create other ways to connect people, using humor. Oftentimes we have some fun contests for our physicians that are COVID related and just, lighthearted things like that to try to keep the spirits up.
Okay, well, that's great. Thank you again, Sam, for taking our time today. And thank you to our audience for all the sort of lively sort of engagement and questions. We will continue our Grand Round series. Our next sort of Grand Rounds is next Friday on radiology preparedness, radiology department preparedness, and we have some national leaders there as well. So that is it for today. We will have this recording hosted on our website at healthfortheworld.org/academy and also on YouTube. So looking forward to more engagement. Thanks again, Sam.
Great. Thank you for the opportunity. Thank you, everyone. Bye.
Yeah. Bye now.